Next up, we'll have Dr. Reardon come on up and talk to us about TMVR.
Well, thank you, Steve. So transcatheter mitral valve replacement, hope or hype, it really depends on how you want to look at it and what patients you're talking about. My conflict of interest is I do sit on the advisory board for the Intrepid Early Feasibility Study and for the Apollo IDE trial for the Medtronic transcatheter mitral valve. So we want to talk about this, we really have to start off by separating primary and secondary mitral regurgitation. They are fundamentally different beasts. In degenerative MR, primary MR is not functional or secondary MR. Dr. Laurie has given you a talk about mitral valve repair for primarily degenerative or primary MR, and what he showed you is that good surgeons can repair it 100% of the time, and if they do that, they'll return you to the normal population survival. There is no prosthetic valve I can put in you in any position that will return you to the normal survival curve. Functional MR, secondary MR, is a different animal, and we're going to talk a little bit about that. So with mitral regurgitation, we know with primary MR, it's a problem with the valve itself. And if you do it properly, again, as Dr. Laurie has shown you, you can fix that valve. And when you fix that valve, the patient gets better. Secondary MR is not really a problem with the valve. It's a problem with the ventricle. It's a problem with the heart. And we continue to argue about whether or not the MR is just a marker of a bad disease or a driver of this. Now, we know that if you have MR, it becomes a vicious cycle. If you leak your mitral valve, you eventually get a bigger ventricle. If you get a bigger ventricle, you get a bigger annulus. And mitral regurgitation gets worse and worse and worse. So one of the things we've always been taught is that mitral regurgitation begets more mitral regurgitation. In fact, Dr. Laurie will tell you that people that repair the mitral valve and do a bad job of it, the people that come out of the OR with mitral regurgitation will, over time, generally get worse mitral regurgitation. That's why when he comes out, he does an echo, he makes sure he comes out with none, because mitral regurgitation begets more mitral regurgitation. So good repair in primary improves survival and improves your quality of life. The rest of my talk is going to be mainly about secondary mitral regurgitation. So let's talk about the data landscape. Let's talk about the randomized trials, surgical versus guideline-directed medical therapy. Let's talk about surgical repair or replacement in a randomized trial for secondary MR. We're not going to do it for primary MR because everybody of any knowledge agrees that you should repair these valves. And transcatheter repair versus guideline-directed medical therapy, which is a little bit of what Colin talked to you about. So we'll look at all the New England Journal papers, which are all the really important ones, of course, right? So this is surgery versus guideline-directed medical therapy. Not much there. In fact, there's no randomized trial of surgery versus guideline-directed medical therapy that's out there. Doesn't exist. So we don't really know what the data is for surgery. Surgical repair versus replacement for secondary MR, well, there's a couple papers that are out there, and we'll talk about those that come on. And then Colin just showed you the two ones, the MITRA-FR and the COAPT studies, both of which came out simultaneous with their, in a simultaneous edition of New England Journal of Medicine. So is secondary MR bad? Does correction of secondary MR matter to the patient? If it does matter, how best to correct it? Those are kind of some of the things that we really need to talk about if we want to talk about transcatheter mitral valve repair and whether it works or doesn't work. So is it bad? Yeah, it's bad. About 40% of heart patients have moderate to severe MR. Secondary MR is associated with a poor prognosis in heart failure patients. Secondary MR worsens outcomes in both ischemic and non-ischemic cardiomyopathy patients. Secondary MR contributes to heart failure progression, symptoms, poor clinical outcomes via increased ventricular loading and increased left atrial pressure. And secondary MR has become a target for heart failure therapy. So yeah, it's bad. You don't want to have secondary MR. And if you have secondary MR, the worse it is, the worse you do. But even small amounts of secondary MR tend to be bad for you. And this has been shown over and over again in multiple studies. Again, there's always been an ongoing argument of, is the worst MR worse for you because it's making your heart worse, or is that just a marker of being worse to begin with? Now, this is a paper from the Cleveland Clinic, and it's looking for people that had secondary MR, and the one-year mortality was 20%, the five-year mortality was 50%, and by 5 years, 90% of them had either died or been rehospitalized. Again, these people were living miserable lives until they die, and then their misery's over, but it happens fairly quickly. So yes, having secondary MR and heart failure is a really bad thing. So again, is it a cause or a marker? Is it the valve or the heart? Something we continue to argue about. Well, this is from Joanne Lindenfield's, when she was talking about the COAP study, and I've taken part of her slide. I've stolen this from her. And this shows the trials of guideline-directed medical therapy and heart failure. Guideline-directed medical therapy works. That's one thing that all of us that were involved in COAP learned, is we'd send these people up to the screening committee, and the screening committee would send them back and say, no, do this, and we'd treat them, and lo and behold, they got better, and they were no longer a candidate for COAP. We lost half our patients that we tried to get into COAP because they got better and we treated them better. And these weren't people being treated by yahoos out in the country somewhere. These were people being treated by our heart failure people. And they still got better when you improve their medical therapy. Medical therapy works in heart failure. And COAP made us very acutely aware of that. So guideline-directed medical therapy works, secondary MR is bad. There are no good randomized trials of surgical correction versus guideline medical therapy. So how will this surgical correction work? Well, there's two really types of secondary MR. There's non-ischemic MR, where the whole heart gets big and this barrel splays out and the papillary muscles are both pulled down and out. And then there's ischemic, where generally you have a posterior papillary muscle that moves out and it's pulled in one direction. So surgeons have always wanted to repair things. Dr. Laurie's already shown you in primary, we have good repair results. They work. But how about for secondary MR? Well, Steve Bowling early on said, okay, we're going to do this with an undersized mitral repair ring, really kind of a right-sized mitral repair ring. And he developed this operation that everybody referred to colloquially as ring and run. You go in there, put a ring in and get away very quickly. And these are people with all bad ventricles. We thought if we repaired these ventricles, they might do poorly. But lo and behold, a bunch of people could do this. They could do it with a pretty low 30-day mortality. So we were pretty proud of ourselves. We could put these rings in, we could kind of reduce the MR, and we weren't really killing people. But then a bunch of papers came out with a lot of contradictory results. We do it, it's great. We do it, it's not great. But when Steve looked at his own works, by the time he got to 3 years, absolutely no benefit. Zero benefit rather than just treating these people medically. So again, you lost a little of enthusiasm when you're doing an operation, even an operation with relatively low mortality, if it doesn't benefit you. Now, we looked at that and said, well, what's happening? Well, there's a lot of recurrent MR. And if you have recurrent MR, these people are going to do badly. So we looked at why people got recurrent MR, and what we found is that you went up to more flexible and partial rings, the MR went up. It got worse and worse and worse. So lots of surgeons designed rings. And these rings were all rigid rings, and they all were shaped to try to put the annulus where it should be in systole. And after a while, if you didn't have a ring named after you, it was like you really weren't a very good surgeon because everybody had their own ring. The problem is, when there's a whole bunch of rings, that means nobody knows what really works. And people are still kind of fishing around. So we figured out the ring, so we got this now, right? We're good surgeons. We now have the right ring. We know how to pick the right size. We now know the right implant sizes. So that's good. So now let's test our theory. So CTSN then said, we're going to have a randomized trial. We're going to randomize between repairing and replacement. Because we know if we replace it, we'll get rid of your MR. So let's see how we do if we repair it. And this is the 2-year paper by Dan Goldstein. Mike Acker did the 1-year paper on this. And lo and behold, at 2 years, there's no survival difference between mitral valve repair and mitral valve replacement. The problem was, by the time you got to 2 years, if you had a replacement, 2/3 either had moderate or worse MR back or were dead. 2/3. Now imagine if somebody came and said, I want to do an operation on you, and it has a 2/3 chance of leaving you either dead or not working at 2 years. How many people would sign up for that operation? Not many. It's really still obviously a problem with our ability to repair functional or secondary MR. Now replacement got rid of the MR, but there's really more of a higher upfront price to pay. And all these replacements are done with preserving the entire subvalvular apparatus. When I was a really young surgeon and Dr. Cooley first taught me how to do this, we just cut out the subvalvular apparatus and put a valve in there. It was technically very easy, but once you disconnect the annulus from the ventricle, that's a bad thing. Dr. Laurie's shown you how these interact. And you take away that interaction, and you lose 15% of your cardiac output off the top, and it gets worse over time. But even if you preserve it, there's problems there. So there's a higher upfront mortality for mitral valve replacement, more heart failure and readmissions in the repair group. But for those that had repair that it worked, they actually had a lot of ventricular remodeling, looked pretty good. The problem was it was only about 1/3 of them worked. So current surgical repair techniques for secondary MR really are not optimal, but when successful, show promising results. So it still leads us to believe if we can kind of fix MR entirely, we might make these people better. So how about transcatheter versus guideline-directed method? Khan's already done this. I'm not really going to dwell on it because he did a great job. But I think it's important because we now have, for the first time, a trial, the MitraClip trial, that shows that it actually helps people with heart failure, much in the same way that guideline-directed medical therapy. And of course, surgery is still sitting out there. So what MitraClip shows us is that mitral regurgitation in and of itself is bad. In fact, when we were at TCT, we were sitting there, I was talking to Steve Bowling. Steve is a surgeon at University of Michigan who has pushed this repair technique. It failed. And somebody said, well, Steve, you feel pretty bad now that this has shown that they can fix it with a catheter and actually improve survival. And he said, no. What it's shown me is what I've said all along. Mitral regurgitation is bad. Find MR, fix MR. The problem was we just weren't fixing MR. If we fix MR, people get better. And that MR in and of itself is bad. It's not just a marker. If we fix MR, people can get better. So if MR is bad, not just a marker, safe elimination of mitral regurgitation should help patients. So TMR is likely to be hope, but we have to eliminate transapical access, which is the way most of them are done right now, and it's going to be for a very limited number of people. And indeed, trying to come up with some repair technique that works is still a better option. We're early in this. I'll say that we've been part of the Intrepid trial for a year and a half, and we've enrolled 5 people. I run the screening call with Scott Lim from University of Virginia. We have 58 sites already in. We screen about 6 people a week, and half of them screen out for some reason. So it may be a hope, but it's still limited. But remember, when we started TAVR had a 50% mortality when we started. Now we do it on a day in, day out basis. And I think what we're finding right now is that we're very early. Also, the companies have invested over $2 billion in this. So they have a vested interest in making it work. So I do think it's going to be a hope, but it's going to be a hope for a limited number of people. The next step we're going to take in Intrepid is we're already working on a transvenous transseptal design. I've been up to Minneapolis and worked on this, and we're also hoping that at least as an interim step, get away from the cardiac apex. Putting a hole in the apex heart is bad. We want to do this transatrially. Thank you very much.